getting the chair. Should we start? Good morning to everyone, first of all. And thank you for coming out on a nice sunny Monday. I know that it's a Sunday, but hopefully it's going to be a good day that hopefully we can show something that you can put in practice. First of all, I wanted to thank Raj for having us today, for doing this live demo. The other day, when you do a live demo, it's not something easy. Sometimes can be even tricky to take on board because things they might not go right, but hopefully we have a solution. We have a backup denture. No, I'm joking. We don't have a backup denture. We need to do it right. First of all, congratulations for the practice. Raj is a client of Vivo for many years now, and we've done many cases with him. And the kind of thing that I kind of enjoy seeing him doing, especially is now how he's using the laser with surgery combined. Raj offers sedation in his practice, of course, and many other treatments. So, and he's somebody that I like the way that he thinks about the cases. So, and he helps also the lab to build the case. So today I'm gonna just quickly show you, have a bit of a thought of how the cases are planned. It's not just wherever comes. There is a lot of more thought behind, and I'm gonna show the Inserta word. Inserta, as I always say, has never come out like an implant, just an implant, because the implants, thank God, there are many out there. But it's more about the system and about giving a 360-degree view of surgeries for singles, for full arches. I'm just gonna quickly go through guided surgery. Do you all do guided surgery, first of all? Yes, full arches, yes, I know you all do full arch surgery, yeah, good. One of the most important factors for me, I'm the owner of Vivo Dental Lab, for whoever doesn't know me, and I'm the owner also of dental practice in Hammersmith. And we mainly do implants, okay? And one of the things that I always had in my goal, and I don't like to do things normally, I like to kind of think out of the box, is to create a practice where I don't have to have anxiety what is going to happen in the surgery. So, and I found that route for me was guided surgery that was protecting me by maybe the surgeon doing something wrong. It still can happen, still can go wrong, but we are starting limiting errors. So, and for me, the safety of the patient is the first. So, in this video here, you see that one of the dentists works for me, 2021. He says, Eddie, take a video of me placing the implant, okay? Because he was cool on social media, blah, blah. As you can see, he went in 900 RPM. So those are the kind of things that guided surgery sometimes can avoid you, because you can be tired. Sometimes I have surgeons that they are heroes. They want to do 3 cases per day because you had a good day, that 2 surgeries, they went well, then overconfidence, but then you start being tired. That's why even today's case, we planned to do in the afternoon. Then I said, guys, for me, the afternoon is like for the siesta, to go and sleep, to have 1 hour nap on a Sunday. So let's do it in the morning, that we are fresher, we can perform and very well and be focused on the patient. And for me, guided surgery is like a pilot with all the instrument that has, is to guide us in the right place, and also is to plan things because before an airplane takes off, there are a lot of checks that pilots they need to do. Okay, and even today's case for me is an extreme case. You're gonna see it's not an easy case. It's a case that has massive anatomical defects, has a skeleton defect, so the upper is very low. So how we are going to plan all these kind of things? Thank God now we have a lot of experience through those cases. So the other day Raj sent me the case and said, Eddie, you plan it together. We went on a Zoom, we did a small video and stuff, how I thought about the case, and we agreed. But there is a lot of thought behind, because for me the most important part is the planning. Today I'm quite relaxed. I don't have a denture. I honestly don't have a denture on my back. not because I'm overconfident, but because I know the situation, I know the patient how much bone has everywhere. I know that we are not struggling. I know that if one implant goes wrong, we have other sites, many other sites. And then I started developing a lot of the guided surgery for my practice, first of all, and then it ended up that I was using, I was a great believer, I'm still believe that it's a very good product, the Sweden Martina products, but then I want to make a lot of changes because prosthetically, in certain areas didn't work, in certain areas I had issues, and at the end of the day, we couldn't work with R&D properly, and I decided to I said, I'm gonna do my own, especially to use it for my practice, because for me, the biggest cost that I have in my practice is the chair time, is to run displays. And for me, it was like, I want to give time into the surgeons to do it, not because I want to put them pressure, but because we need to maximize, because at the end of the day, we're not here to save the world, we are here to also do business. And I start then working on this implant. I wanted one connection, two implants only, P3 and P1. One is a bit more self-tapping, more aggressive. The other one compacts more, so I wanted one for the upper is the P3. For the lower, I would use, and I would recommend using more the P1. And then the part that I kind of worked a lot more, I spent a lot of nights, was on the prosthetic parts. Okay, starting from the impression coping. So, guys, I'm telling you things that they come from me, from Eddie Marco. Don't take it as they are right. Take it as what Eddie Marco is going through, and I'm still going through, because I believe that there is a lot of evolution in dentistry that can be done. It's just somebody needs to have the courage to start doing, because can somebody explain to me why an impression coping, Nobel Biocare, Straumann, it flares out like this? My impression coping is completely straight. Why they need to flare out? If sometimes you have put subcrest on the implant, it's gonna go and touch bone. You need to take PAs. In here, if you want to take PAs, you take PAs, but it's not needed. Because that impression coping will never ever touch bone. Because it's with the dimension. If you had access to the screw, it's with the dimension of the access of the cover cap or the healing abutment, wherever you have used. So, and then I start thinking about the lab side of it, because when you take PAs, the lab sometimes uses the wrong tie base. So it gives you too much compression, or sometimes it doesn't give you compression at all. So my idea was that I wanted to create something that the lab has information. So in my practice, as a procedure, there is always that they need to take a PA of the impression coping or the scan body in place. And those lines, they just indicate millimeters, and also they indicate what kind of tie base the lab needs to use, okay? Because when they receive a PA, how it works, at least at Vivo, that the case comes in, we check it in, and Alberto or Andreas, they will order the stuff, all right? But sometimes they struggle to order, or they might order the wrong components. That's why then we need to have a big stock, because they don't have enough information. They just see it from the impression, yeah, here is a 2 or 3. When if we have a PA, I can go and see in that case which tie base I need to order and how I'm going to start the emergence profile. So I'm giving some lines to the technician to do the right choice. They are small things, guys, but trust me that for us, they make a massive difference, okay? Then the scan body, we did the same thing, but because had the treatment, the lines, they couldn't be shown. So now, well, the new version is going to be having lines as well. You can see them visually, but you cannot see them on the PA because they just made them with laser. One analog, the tie base, they are different heights. And then we come to different solution that I needed for angulation. I'm not a big fan of the angled screw, that you use the 25 on the fixture head directly. So even there, then started this idea of how to do it, how to restore those kind of cases. This is a case that came to the practice, was like 2 weeks before the wedding of her brother. And she came there, she said, listen, I do not have money, blah, blah. Can you do me something? that was in her budget. I think it was a really good case for presentation, and was a really good case to apply this kind of technique that we do in my practice, that sometimes when the case is an easy one, we will put the final crown immediately on the day of the surgery. So, and I explained to her, I said, listen, usually on the central, it's not something that we do, but there is this option that on the day we are going to place the implant and we are going to give you the final crown. Might be just a bit twisted, might not be super perfect, but will look natural. So, how we did this case, I give a jig. Here was used a 17-degree Profilo. I gave a jig to position this is a zirconia crown, okay? He placed the implant and immediately placed the crown. The crown was already cemented, so on the day of the surgery, you will not do pickup. And I was allowed to do this because I can already predict the angulation through the guided kit where my angulation is going to be. It can always deviate 2-3 degrees in rotation. But if you use loops that you align the notches perfectly to the line, will come quite spot on. Okay? So then the patient comes for review in 1 week, and now she came for review in 4 months' time, and the papilla that had a gap in the beginning has filled up to here. And this is again to come back to the experience that I gained with the concept of the Prama by being very small with the neck, with the components, to leave more space for tissue. Okay, can you see how the papilla has filled in the middle? For me, he has done a grafting that was not necessary because he wanted to do a super nice case. And this is a very good example, for example, that when you want to overcomplicate things, you go in an area that you don't know. When my idea was, I said to him, you just make an incision a bit more palatal, you just move the tissue, you detach the periosteum, put the crown, and then the shape is going to be much more natural. Even for FP1s, when you see people like Ramon Gomez Meda, that they do a lot of grafting, tissues, they are never nice and natural. They are always a bit scattered because they've been opened many, many times. But hopefully will heal. Here is another case. What would you do in that case? That is the prosthetic area, and you have this angulation. So this is a client from Ireland. I did the same thing. Can you see? The crown is already cemented. The crown is already finished. It comes in a jig and has a hole. So he does his preparation. He places the implant. You can see he aligns the notches. This was a 30-degree. And the good thing about it, that with this abutment, with the Profilo abutment, I tried to combine a lot of concepts. One abutment, one time. We have a platform switching. So this abutment, once you have placed it, it's not thought to be removed. Because on the day of the surgery, once you have placed the Profilo, you want that the biological seal to don't touch it anymore down there, close to the bone. Now you're just going to start working tramucosa, okay? Because you can see where the connection is. It's not deep there. Deep there, you have the seal, you have the myoblasts and fibroblasts that they have attached to the Profilo, which has a UTM surface. You will not touch it anymore, and it's angled. This is angled 30 degrees. And what he does now, he just takes this crown that comes inside the jig, he positions it, and through the access that we left in here, he will screw it. That's it. Crown in place, you can see even the contact, they come right. So if we have a lot of good information, and the guide is made, because even also is the lab side that needs to come good. Because if the lab makes you a guide that will start rocking or will leave too much undercuts, then the guide can have a bit of a movement, and even the position of this crown will change. Because you don't want to leave the crown in tension against the other teeth on the day of the surgery. Then he did a bit of stitching to stimulate a bit of papilla in there, and that was the X-ray. But you can see that the nice thing that I like about the Profilo, that you would always see bone growing over your connection of the implant. Always, unless there is an infection, something going on. It's not a requirement, but personally, visually, I like to see it. It gives me safety. It gives me an idea that I know that it's healthy. We have the straight, and then we have the angled 17 and 30. And then a bit about the prosthetic components, and this is something that some of you know you never seen, but the people that they work in my practice, when they start working, the kind of thing that I usually do, I have a box like that one full of components: Straman, Neodent, Megagen, Inserta, wherever. I throw all of them together and I say, you need to put the implants together. Because the kind of thing that I'm still shocked and I'm very upset of, the dentists, they do not know components. You need to know your components, guys. You need to know which screw goes where. Because sometimes an easy thing. I was up in Scotland, he had to use, we saw a patient, he placed the implant freehand, was not, I couldn't angle because was a Sweden Martina, because he did not realize that he used an angled screw, the dynamic screw, he ruined them. All of them, he tried to screw, then he tried to unscrew, was 5 o'clock in the afternoon, I had to catch the plane at 7:30. Then from that mistake, I had to cancel my plane, which is not like the end of the world. But why do it? He did it because did not know the components. And I always insist that you need to know the components. That's why I try to kind of simplify, to have one screw, one screwdriver, one impression coping, one analog, plus a digital is one. Here, just to show you the difference, this is on a straight abutment. So the normal multi-unit, which is my enemy, I very hate it very much. So it has a 1.4 screw, has a 4.8 platform usually. Straumann, they have 4.6, some of them. And then has this beautiful access. It's like you do a nice crown on a natural tooth, and then you leave a cavity. Because this is an area where bacteria, they go in, and you cannot clean them. And the patient cannot clean, of course. So this is the Profilo straight, and look where it comes the normal multi-unit. So if you ask me, would you like to have here more titanium or more tissue and bone? I usually like to have more tissue and bone. That is the kind of idea that I have in my head, but maybe I'm wrong. Okay, the Profilo has a 3.5 connection. Okay, and the first version was with a 1.8 screw. Now the new Profilo has an octagon and it has an M2 screw. It's quite thick and chunky because one of the reason for failure is always component failure. Why implant? Because things, they start moving. So I wanted to bring the biggest strength, and I took the M2 from the Synocta of the Straumann, which we did a research on the market, which one is the strongest implant, dental implant component, is the M2 for the Synocta. That is the strongest screw on the market because it's short, fat, and resists to huge torques. If I take that screw and I screw it with my screwdriver, unfortunately, the screw will not happen anything, but the screwdriver will bend because I can go up to 55, and the screwdriver will start bending. But the screw doesn't happen anything. So, and it has a lot of room if you want to keep doing in and out, in and out. And because it's short, one of the things that happens in the long screws that they stretch. That's why after you screwing it 3 times, by rule, you should change them. But because it's short and it's wider, we can do like 3 times more. So we can go up to 9, 10 times of tightening, bringing in tension. Okay. So the Profilo, just for your information, does not have any access on top. All right. The Profilo will screw directly into the implant, and then you will place the implant and Profilo in the mouth all together at once. So you don't place the implant and then the Profilo. You can also do that, but it's not like with the normal MUA that you need to go and find the hexagon. Because here you'll create your location with the Profilo, you can torque it. The Profilo hearing connection with the mounter is tested up to 170 Newton, 160 Newton, which is a torque that you don't need to go usually. You know, it's an excessive torque, so do not go. We have different heights, 1.5, 2.5, 3.5 for the straight, 17, 2.5, 3.5, and then the 30-degree, 3.5 and 4.5 height, okay? Profilo, again, one impression copy, one scan body. And how it works. So the Profilo will come all mounted. It comes as one piece. You go and screw it into the implant. The implant has a very clever mechanism that whilst you are screwing, to let you know, but in your hand, you will feel maybe later on in the camera, we can record it. It does a click. It means that the Profilo has been screwed. It just screws a bit. Then you just remove it and you go in the mouth. And then, because of the dimension of it, in this area, it's 2.8, full metal. Full metal. The normal multi-unit has a passing screw that in this area has 0.34 of a titanium. This has 2.8. So which one is stronger in terms of taking loads or braking? Which screw is stronger? Is the 1.4 or the M2? Yeah. And then bone profiling to allow the multi-unit to sit. Go and sit here, multi-unit. You need to do bone profiling. But there you would like to see bone that grows over or not. So with the Profilo, you will never need to do bone profiling because the Profilo is smaller than the actual implant. So it can go in and then you just see that bone there on the healing phase that has grown over. That is a direct way of doing it. So you will take Profilo and implant all together. This is indirect way. So now you think that I have a very high torque with my implants, I believe, because I can see that I have a lot of cortical. So I will first go with the implant in and out until I sit it. And then I go and put the Profilo. But you don't need to align it like you would usually do. You will just take it with your handpiece, go in the mouth, and will auto-screw, auto-center itself. Until you bring it to the position, to the right timing. Because we have a notch on the sleeve. So, and the notches, they need to be aligned. This is straight, but you can see here, this is the thing that I kind of like to see every time. And a question that we always get asked, can I do a single? So some of you, I know that you use Prama, okay? So Prama has a 1.8 screw. And the connection of the octagon, we have it 1.6. A normal hexagon is 1.3 that goes inside the connection. So we have 0.3 more, mechanical, to give more mechanical resistance, and we have a bigger screw. So you can do a molar, you can do anything. It's not just done for a small single or because it's this kind of idea sometimes. No, but I did because maybe it's gonna move because it's a small connection. No, actually has a big screw, and even the part that gives the resistance to the lateral forces is taller than a normal connection. Then a cone Morse is a different story. This is a simple case, two laterals, and in this case, actually, I couldn't think about anything else. The client was not using Inserta and Profilo, and I sent him this picture. So, because for example, with the Prama, my guys in the lab when they used to do planning, because it doesn't need an MUA. When you put an MUA, it becomes big and wherever. They will try to angle always the implant like in the first image, so we can keep it in the prosthetic environment. Okay. But then sometimes we used to have perforation or implant placed too palatally. And here you can use the 17, it's not enough. Then you have the 30 option. And the Profilo, the difference from the Profilo to the normal MUA is that The normal MUA will bring the whole axe here, will be the axe, because it shifts the axe. When the Profilo turns on itself, so the axe, even when you do a central, will come in the middle of the tooth. Because sometimes I used to do buccally beautiful teeth. I remember lateral, I spent like the whole day to do this lateral. Because it was a young patient, blah, blah, I used to work in Teddington, Wool Harper. One day to do one lateral. But then palatally, we were massive. So I did it. Now she likes the color. She says to me, no, but I don't like the feel from with the tongue. Because palatally, she felt that it was bigger. That's why now with this kind of curve that you do in here, you can make it look like the natural teeth. You're not coming more palatally placed. Sorry? Yeah. You have different heights. Yeah, the implant, you will place it normal, bone level. Yeah, and then you have the biological width that is 3 to 4 millimeters. So you will place it 2.5, so then you have 1.5 from the Profilo to the CJ of the tooth. So it depends, you know, for example, this case, look where the implants were coming. Very young patient, and the client said, no, but Ellie, I'm gonna do cement. Of course we can do cement. We couldn't angle with a dynamic screw. Of course we can do cement retain. But I said, listen, you know, this was in the beginning when we were just coming out with Inserta. I said, I have this abutment that I have invented. It's a very cool feature. Do it like this. I literally just sent him the case and the kit, and he did it by himself. And I was kind of scared. It was during Christmas 2 years ago. So he goes by himself. He does the surgery, and can you see how the abutments now they come straight into the tooth? Can you see? It looks like the implant is going out, no? But look at the position in the middle of the tooth. He printed he's got the Midas from Spring Ray. He printed himself in house, the temp. He did the pickup. He did the pickup himself. He kind of polished it. Patient after 2 weeks of review. But a kind of difficult case, I like to see that becomes simple. This is my idea. I don't want to compromise anymore my lab that just they try to find the prosthetic space and to put it in the middle of the tooth with a fixture head implant. Now, yes. Yeah, food we are gonna get if the case goes right, as I told you. If the case doesn't go right, no food. All of us, we don't deserve it. So, just a simple case, you know, that can be managed simply, sometimes can become complicated if you don't have this kind of abutment. All right, here again, the same case the patient had a really deep bite, prosthetic was coming there with the multi-units. We put Profilo, blah, blah, blah. Can you see how you align them? He did place them. And then the nice thing about the Profilo is that it's not big. You have space to go and fill the jumping distance. You have space. You don't need to place it later. You have space to fill this area. It's not a normal MUA that is going to go and close the space. In this case, he did something I personally don't like and don't agree. He put the temporary cylinders, he put the bone, and then he did the pickup. When my idea is always first do the pickup, finish it, clean it, leave it in disinfectant, do your grafting, and then with your graft, you will go and sustain your grafting. Okay? You will go and compress it. And then especially when you do those kind of cases on the centrals, on aesthetic zone, when you remove the teeth, you know that all the attachment has gone. So you see that this papilla has collapsed. And I already said to him that you're not going to have massive papilla there. Okay? So my idea is always that if you don't do massive grafting or you're not good at grafting, just sometimes detach a bit the periosum at the front, put a suture here and go over the bridge. I would have gone simply. And then I would just put some material, some grafting here just to sustain this. Because then the cloth is going to keep it there. Does it make sense? In a very simple way. And this is, and you can see that the papilla here, you see how it is, has dropped. Even when we do, and then when we go to full arches, we treat the full arches. I treat the full arches like we are treating two teeth. It doesn't have any difference. It's just times 14 teeth. But you can see how much space, how much volume we have buccally, because we are small and looks pretty healthy. Then to come here to the full arch stuff, and this is then the kind of guided for full arch, what Raj has shown you before, that I kind of like, because we used to have failure on full arches, and always the reason was because the bridge has broken somewhere. So then sometimes you have 2-3 teeth in one implant. And even that we used to put an reinforcement with wire, we used to have those kind of problems. So this is how we do it today. We have the positioning guide. We have the preparation guide for the implant. Can be done in 3 ways now. The first one is completely milled. It costs a lot. The second one is laser melted, will kind of tie bases, and then the third one is completely resin. Personally, the one that I use most is the resin and the middle one. Why? Because of the costs. In the end of the day, but the most predictable one, this is I want you to keep in your mind. Don't think that is the metal. The most predictable one is the one in resin, because we can get much higher accuracy with resin than with metal, because the laser melted, it's powder that drops, and then a laser, it melts it. So it goes in higher temperature. Anything that goes to higher temperature always has a compensation in position. Okay? And then we put this titanium reinforcement inside to give strength. And that came also as a need for me in Hammersmith, because I was spending a lot of money marketing. A lot of patients coming to me, yeah, I want to go ahead. The clinic looks beautiful. I like your dentist, but I cannot afford it. So then that bridge became my semi-permanent, that we put a 3-year warranty on it. Okay? So in the way that I do it in my clinic, I also have a small lab. So when we do the pickup, I remove a bit of material of the pickup, and I will inject new acrylic, and I will put in a high pressure cooker. So the material will go and bond properly. Unfortunately, I cannot do this across other clinics because sometimes they don't have space, they don't have the equipment. And that case that I just showed you, the guides, is actually this case here. The lady came to our clinic. So it was not a lady, it was a man. And he said, I want to improve a bit cosmetically. Okay. And then we showed different option. We said, yeah, we can, I want just to do a different denture. And then we went for a full arch. But this is a way to show you that even on a dangerous case, you can start thinking. Whoever knows me knows that I'm a guy of FP1, so I will, whenever I can, I will go for an FP1. So in this case, what we've done, because the patient had was showing quite a lot of teeth, and we could see the gum, we went for an FP1 option, and I made a guide based on the design of the teeth, and then I hollowed that guide to guide the dentist where to go and do the contouring, the soft tissue remodeling, just with a burr. And then I get always this question asked, like, how much do I need to remove? You just need to break the epithelium, because the epithelium is the layer that we have more fibers, that they are not so elastic. They are tense to each other. So once you've made there a hole, can you see it's good enough? You don't need to go over, unless the lab will give you instruction that you need to remove bone. And then from there, we end up to here on the same day, on the day of the surgery. But simple. And trust me, that nobody that you will go on a course of FP1 will tell you that it can be done in this way. Because they will open the patient completely, done grafting, more grafting, but how many people they can do that? When my idea is always like to keep things more simpler and predictable, because not everybody can do certain stuff. And trust me that whoever does that way of grafting will never get this tissue, never in 1,000,000 years. Because I keep the tissue of the patient, I just play with my prosthetic. So my laterals, I open them up, so I leave the papilla here in the middle. If I close them and you do me grafting on top, you will never still have the same amount of papilla. I just play with my prosthesis and with my planning. And then if you're lucky, you get this kind of bites. If you're lucky. This is just after the pickup. You can see it's minimally invasive.
In this case, is it vertical dimension changing?
Sorry?
Is the vertical dimension already is changing? Because we're not putting the bone. So where can we get the space for the prosthetic bone? All the implants are subcrestal?
Subcrestal, yeah. Yeah. But the prosthesis doesn't come big. Like the prosthesis comes really small. Yeah. What do you usually do? You will use neodent, you will use a multi-unit. So where do you get the space for the multi-unit? What do you mean? No. Even on FP1, you don't cut the bone. No. Don't need to cut the... If the case needs a cutting bone, of course we're going to cut bone. But if the case doesn't need bone, you don't need it because the bridges, they are reinforced. You know, they are reinforced.
Yeah.
They are reinforced with metal, with titanium. It doesn't make sense. So you don't need to create that famous 20 mil or wherever my grandpa used to say in 1920 after the... Oh, we can do that later. What would you do in this case? FP1 or FP3? Of course, here, FP3, and we create the space. Of course. He was done a dental by design with a client that was coming from Scotland. So it was done in my practice. And the surgeon was his second time in his life doing surgery. So he was kind of shaking. So, and he said, Eddie, what do you need to do? I said, an FP1. I said, he's going to have a very nice case. You need to make an incision, roll it against the bridge. Man, he said, can you ask somebody else to do it? I do whatever you want. I work all night. No, but then in the end, he did it. So I planned the case. And my idea was that here at the front, I had a bit of space to compress. So, and I was hoping from the back to gain a bit of volume. And the volume, there's nothing clever. We just make an incision, we open it. Once we have fitted the bridge, we suture this tissue against the bridge. Nothing Zucchelli style. It's more like friendly, three friends at the bar. But what is the first thing that you will do in this case? What is the first thing? Increase the OVD. So in this case, what we did, we increased the OVD, we did a mock-up, we left in the mouth of the patient for 2 weeks, we rescanned everything, and then we started going ahead to do our surgery. Okay? Then put cylinders in, we place the implants, we did the pickup, I polished the bridge, and we put it in. No bone removing, no nothing. Just by pushing the tissue at the front and opening the tissue at the back. Sorry?
Did you train them in the OVD or just
Train for 2 weeks. And then trust me that all these kind of concepts about the OVD, the patient, unless you do something crazy, the human being, we are so lucky that adapts to everything. Okay? Unless you do something crazy, we'll adapt. This is another case. Sorry. This was another case, and you can see the kind of volumes. And I know that with this amount of tissue that I have around here, my bacteria will not infiltrate, do whatever you want, will not infiltrate and go down there. I do not agree, even that we have the 1.5 straight, I do not like it personally, because I like at least from 2.5 and above. Because if in case of bacteria, first of all, I give more space for the myoblast to go around my abutment, but has more space to go through and attack and cause periplantitis. So usually I like the 2.5 and above. You can see here. You can see how much thickness we have. That is just volume reinforcement, and this is how an X-ray looks when you use the titanium bar. Okay. Now we come a bit to more what we are doing today. Today's case is a similar case to this one. It's even worse because it has a skeleton defect in protrusion. What would you do in this case? How would you approach it? Because I know that you know how to do it. I know that all of you know how to do it. But you tell me, I'm your technician. You come and tell me, Eddie, so in this case, what we are gonna do? We are gonna do first step, reduce the bone. Yes, thank you. How much? Where? How would you do it? You will reduce it to here. Okay. How much bone you got? This is a very clever question from my uncle, though, that is a builder. Guys, you need to know anatomy. If somebody has this kind of position, you don't ask for bone, please, 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 please. You don't ask for bone. You have bone. Always, always, there is a skeleton defect that has protruded. You do not ask for bone. Because when they tell me, I don't know how much bone it is, you should know. At least 25 millimeter and above. Always. The case of today, I didn't need to ask Raj how much bone it has. I know that we have kilometers of bone because there is a skeleton defect. Please. I don't know how much bone. Do you have bone up to here? Here's the nose. Here's the nose. Here's the base of the nose, guys. Anatomy. Yeah, of course, always you get surprises in everything. But in this kind of cases, very rarely. Trust me. I've seen many of these cases. I've done many of these cases. So, and always if you analyze your own patient that you're doing an Invisalign and you take a CT scan, you know that a narrow arch shows a lot of teeth. A wider arch doesn't show teeth and has small teeth. So there are certain things, certain rules that they are there. This is a class of Wickerman, that he studied those kind of things, not me, thank God. Yeah, yeah. But if you do it, that you tell me how much, I'll be much happy. But what is gonna exactly tell me where and how much bone I'm gonna remove is gonna be my DSD and my digital waxer. So based on that, then first of all, his designer designed everything. The practice, design downstairs, decon room there, here, ventilation, and then they start building. But they saw if there was a final plan for them to run the pipe, put the TV here. It's not on the other way around. So my idea is always that you need to have planning. For planning, you need to have a prosthesis. So what I did, I made the prosthesis based on where the prosthesis is gonna come. Then I start working backwards, making all the guides. And there I have fun. Nobody does it better than me. Because I can make whatever guide you want for everything. So first thing, we raise the flap without putting the guide in. Step one, raise the flap completely because we need to remove bone. After that, what we do, we will go and put this guide with the pin and put the fixation pin, so we stabilize the guide. All right? Second step. Third step, we remove the guide, and our guys, they are the only ones that they have just a frontal fixation pin. You don't have multiple screws around. Okay? So you remove the frontal pin, take the guide out, and this is the situation now. Extractions, and then we put this dynamic guide that was designed based on my temporary. Okay? Was done in a dynamic way. There are two ways of doing it. One, that you can go and mark it with a pencil, then you remove the blue guide and we go and trim. Two, that you can go directly with a ball-ended burr and trim. And if you touch this, this is titanium. You know the chrome system? I'm shocked that they still chrome in Italy in a surgical environment is not allowed since 1996 in Italy and Europe. They work here and they work in America because they have different regulation. But you cannot use cobalt chrome. It causes massive inflammations. When this is titanium, you touch it, it's biocompatible. It's there. It's titanium grade 5. It's there. It says there. You can see it on the X-ray. But it's not going to cause an inflammation. But personally, I like that you mark it and then you remove it, if you ask me. Okay? And then what we do, we go and check now the biological width. Now we've done the trimming, even today. We need to go and check the biological width. That we have at least 2.5 millimeters here. Because we want this bone to go even further away. So I want to invade a bit the biological width. I don't want to leave 3-4 millimeters. I want to leave 2, even 2 they are enough, because then I know that my bone is going to remodel a bit. And the body is going to gain its own space. But I know it's going to be very healthy and predictable around that area. So we checked before placing the implants. Here we still haven't placed implants. Yes, was already with the 2 millimeters distance. 2.5 millimeter. That's just to verify, because maybe we didn't trim enough. So we put the temporary, we take the problem, we go measure it. Then we place the implant. In this case, this client, he likes to do section bridges. He does one bridge here, from 3 to 2, 3 to 2, and then the other section bridges. We place 10 implants. You look how they come. We did the pickup, took the bridge out, filled with a bit of composite, and he sutured it. So it looks like this. What is this case? How would you do it? How much you would remove bone? Or would you remove bone at all here? Huh? So 0 bone removal in this case, huh? 0 bone removal. 0. As soon as I see it, this case was done in Coventry, and the client says to me, Eddie, I went there for a surgery. He said, in the afternoon, we have a patient I want you to see. He said, but you know, I don't like the patient. Has been a patient of ours for many years. She doesn't have a good hygiene. I'm not too convinced of doing the case and blah blah, because we need to do a lot of ridge reduction. And here again, it's not a question of there is bone, plenty of bone. And why I start speaking to the patient, I start showing the patient an FP1 bridge, and he wasn't behind the patient. I don't show the bridge. And I said, yeah, so the patient is gonna come like this. And why I said that, because, by the way, these pictures here, do you think that is in a smile position or a relaxed position? That's a relaxed position, guys, unfortunately. A relaxed position. But what I saw immediately, that she's got, her arch is a U shape. So the anterior teeth, they are very forward, okay? The posteriors, they come in the ridge quite a lot. So buccal corridor, no distal support. So my thought was immediately, because I've done these cases before, was I'm going to enlarge the arch, I'm going to bring the anteriors a bit in, and the case is going to be resolved. This was my idea. And then a lot of perio. She had a lot of perio. So when I went to measure, when he sent me a CBCT, let's say the bone was here. All that was perio perio tissue, so no bone needed to be removed. And then I sent him this DSD. I said, listen, you know, the lip is gonna stop here now. From there, it's gonna stop here. I said, Daddy, please, he said. And then he started sending to his friends this case, you know. I said, what do you guys do? Of course, everybody, FP3, 10 millimeter ridge reduction here and there. I said, then I said, listen, send it somewhere else, you know, if you don't think it, I will not do an FP3. I said, because there is no reason. We have tissue, we have bone, why do an FP3? Explain to me. I said, why? We go ahead, I remove the teeth on the model, I do my wax up. And then I do this guide, and he thinks that he needs to trim the bone here. I said, listen, I don't need you, just if you want to trim something here, but when we have perio cases, we'll always go and do a gingitage to go a fast and piece burr and remove the tissue. I would always do them because I want blood, I want clean, I don't want dirty. So I said, you will not need to use that. In the end, we ended up not using it. But with the burr, we removed a lot of infected tissue. I was bleeding quite a lot. You can see the gap that was on the lateral there. Then I go there after 4 months to start modifying the temp because this side was lower. So I wanted to make it the same, but I will show you the picture of the temp as soon as it was removed. This is the picture of the temp removed after 4 months from the day of the surgery. And you can see here, do you remember where it was a gap? Look how the tissue takes the shape of the temporary that you're gonna give, all right? But the main thing needs to be that has to be clean and polished. And even sometimes when you see your patient for review, maybe you might not have it in your practice, but in my practice I have it, and I always will make the nurse go under the polish machine that we have, like a lab polishing machine, and polish them and put them back when you do the trines and all this kind of stuff. Zero perio treatment. Full of pus, nice. There's no need. We are opening everything. Why it hasn't failed? Well, what? But you are cleaning everything. Yeah, you're not cleaning everything. You're gonna have bacteria in there. But for me, if I was the patient, I wouldn't like to be treated like that. Periosation. And honestly, would never make them do, even in my practice. A hygiene to get the environment a bit clean, but not perio. Perio means that there you need to go and raise the flap and clean. It's not, that is not perio what you're thinking. That is a hygiene, deep hygiene. Hygiene, yes, all the patient, just externally. But then when we open, it's always gingitage and cleaning, always with a burr, until you see nice tissue. And then, of course, you need to go with a burr into bone until you feel good bone coming out, particles of good bone. And in this case, the only area where we had the tissue, the papilla was not nice, was that area there that was a bit dirty. Okay? But you can see that the tissue looks quite healthy. And what happened to the patient? That she didn't clean and he didn't want to do it. What happened? If I give you a Fiat 500 and a Ferrari 812, which one you will take more care of? And which one you will clean more? Because you paid it more. And then it looks nicer. So actually her hygiene was not bad. Now she's doing the lower. She's in the process of doing the lower. It was not bad. It was a 10. It's with a 10. With the zirconia super polished, it's gonna come even better. And she's still on. We've done the finals. I didn't like it. Now I made them do it, and we are doing the lowers as well because I wanted to do both of them together. Because they did the bite according to the lower existing lower. I didn't like it, so now once the lowers are ready, we're gonna do top and bottom together. This patient every Christmas she brings me from Coventry to London, brings me present. She will never forget. Yeah.
Is that before you raise?
No raise in here was not raised flap. No, zero. No flap raising. Just with a burr. just to go inside until you see the bone. And then even the tissue, look, you see, because then start bleeding quite a lot when you remove the infected tissue. First of all, you will do with excavators, and cure it manually, and then you go with a bird to help. Sorry? Yeah, yeah. Went on top. In this case, went on top. No stackable, no nothing. Just one, because we had a very massive pallet, and we have good reference. Yeah, you can have a movement, but if you, I always plan like for deviation, or even 1 millimeter in this case, if I don't do stackable. So I have bone backally, palatally, left, right, everywhere. But we are doing something very, very, very nice now. We are working with University of Geneva, and we are doing an analysis from planning to execution using photogrammetry. How much deviation we are having between implants and between the planning. And I'm doing even my practice, all the data. All the cases we are doing, we are documenting with photogrammetry. Actually, it's a shame that today I didn't bring it. Now that I said it. Maybe I can get somebody to go and get it. In Hammersmith. How far is Hammersmith from here? Far. From here to Hammersmith, how far is it? Yeah. Maybe I might get somebody, because it would be good to show them even photogrammetry, I think. Because it's a cool instrument. And usually I see it on the bridge as well. Never. No. Never. What a nice smile. Beautiful smile. We're gonna fix her. No, I designed the file. I don't think. Yeah. And then I start working backwards. All the. Yeah, prosthetically driven. This is prosthetically driven. Listen, the story of I do implants for 30 years and this, well done to you. Yeah. Yeah. Personally, it's always prosthetic. The patient comes to you for prosthesis. She's not coming for Inserta. She's not coming for Eddie. She's not coming for Vivo. She's coming to have a nice smile. Yes.
That smile for the patient.
Wax up digitally. And I shared the case with Raj on Real Guide. This was, for example, was a very extensive invasive case. So he explained it to the patient. He spoke to the daughter and son, whoever came here. But we showed the digital. I can show you on Real Guide. I actually will show you now on Real Guide. Yeah. How? Yeah. To know.
That's a different question.
I make recordings for every patient that comes to my clinic. Every. There is no one patient that starts a surgery without having a video. But it's a video recording. Before we ask what is the improvement you want to make, what are the things that they are affecting you socially. So, but there is always a video, because we had a massive case that one of the clients of Viva needs to pay a lot of money because the patient was accusing the dentist of changing phonetics, changing the speech. We had no proof. So from that I learned, and then I use protocols, I use checklists. So always a video, always, of the patient. No, we put it. The phonetics might change. Even on the, we say that always. I didn't think as well until the dentist was trying to get from us information, but I said, you didn't give me a video. How I can support you. Like, what can I do? So the case, yeah. So the case was like this, and we ended up like that. Is it good? No, it's not perfect because the teeth look, yeah, you're gonna look at the smile, they are a bit long and big, but it's good enough. It's good enough. And in this picture here, is she smiling or not? She's smiling. So now we ended up in a different problem. Now she cannot show anymore the teeth and gum. Because muscle memory, can you see how much I opened the distal? Has filled, and now she struggles to go and show us the gum on a smile. Okay? Because I create a stopper more on the anterior, so she cannot do this retraction by opening the arch distally. Put two chewing gums, or maybe two on one side, and put them on your teeth, and try to smile. Will not allow you. If you have a narrow arch, if you have patients sometimes from 3 to 3, when we used to do cobalt chrome or posteriors, 3 to 3, hello, all the teeth showing. You put the cobalt chrome on the back, they don't start showing anymore. Yeah. No. It's PMMA. It's PMA. Well, nano-filled ceramic. Sorry? Yes. Yeah. Now she's doing the lower. She complained that much that she brings me presents every year to Vivo, and she's doing the lower. We changed her life. She's not complaining. Because for me to fix that to show again, if she had it there before, it's a simple job. Because I know how to do it, and I know how to move the teeth. But if you don't know, sometimes you're stuck. If you are there, but I always play with the arch form. Always play. This is another case, a case gone wrong. It's very important when you do FP1 cases, you need to be fast and take an impression on the final. Because from here, look, I even created distal zeniths. They did the zirconia, lost the patient under control. We ended up in this position. Why? Because it was done in an analogical way. The client took too long to take the impression, and all the papillas and everything collapsed. The lab did not take the temporary as a reference. The client, when they recorded the OVD, they did not record the OVD with the temp in place, so they had the bite block, they just increased it by 6 mil. So always record the OVD, be fast, and the lab doesn't need to design on your traditional impression, but needs to be designing on your intraoral scan. Okay, this is very important because on the trial scan you are much faster than do it analogical way. And this is some of your cases I picked up. Like this, the lab, they were designing, they were doing everything on an analogical way. And sometimes the compression, I don't know, have you ever noticed that sometimes the compression is not right on FP1s? Yeah. You get that, but that is the issue. Because they don't work. I've seen some of your cases that they were beautifully, the temporary, so nice, and then the final, completely different thing. Because this is you as well, you need to tell them, guys, use the file of my temp, because the patient is very happy, or the patient is completely unhappy. But use the file of the temp that we've done the immediate load, because they have it digitally. But what they do, now you send a new case. The other day I was looking at your case, I said, guys, use the brain. They were doing a completely new design, new teeth, no, just use the same file, bring it into the new scan now of the final, and that's it. Send the try. It's exactly the exact copy, just we change the material. Yes. Yeah. Yeah. You have around 7 minutes working time. 7 minutes. where the papilla start losing 25% of itself. How to avoid this? This is now something that I'm kind of crazy about. It's photogrammetry. Has changed my way of working, like in a drastic way, honestly. And I cannot excuse myself for not using it. Patient comes for the final, one scan, one day, the next day it's fit of the final. Next time, not the next day. So they come, we take out, take the intraoral scan of the temp in place, take upper, lower, bite. Then we put the normal scan bodies. Then we do a photogrammetry, so we have a passivity. And then we scan also the temp out of the mouth, another order. And then I can go straight to final. So my final is always in one appointment for the patient, never two appointments. In today's case, is the lovely lady that was outside. Okay. Here, the biggest challenge that we have, that is something we cannot control right now, unless we've done a different approach, is the bite. The OVD and the bite is completely open. And she had teeth and anterior that they were not touching naturally in the past. So I had to lower the OVD by myself, by eye. So the bite today is not going to be quite right, and we are going to stabilize it with some composites on the lower. Does it make sense? And I'm going to show this case on real guide, but I might need my mouse.
Using the icon.
Excuse me? Yeah, I use the ICAM, yeah. I tried all the other systems, I have them, but the ICAM is the one that I'm not having issues. ICAM bodies. The shine, yeah, I use the shine as well. Yeah. No problems, but it's not repeatable. If I take one scan now, I have 25 micron on one side and I have 35 on the other side, 70 on the other one. And next time I retake the same scan, I have 45, 20, 20, 20, it's more accurate. Yes. And the following time, maybe I have more. So it's not like constant. One with diametric, you take it 100 times, it gives you always the same accuracy. Fortune doesn't give us the view. It doesn't give us the view of the screen. It makes everything bigger.
This is software using.
Yes, it's called the Real Guide. 3DM is an Italian company. Okay, so we do want measurements, so maybe we put them later. Let's put them later. I will go on the object list, and I have quite a lot of objects. So the purple is the bone of the patient. Okay? Then, let me start from the initial situation. Yes. There's no difference, I think. It's just the difference that I trained with this in Italy, and for me it's easier. But I think it's a good software too. Just me personally that I'm not good at it. So this is the initial situation, okay? This is the initial situation. What we do digitally, we always separate files, and there are 3 files that I usually would like to see. Files of the teeth, tissue, and bone. These are the information that I need, okay? So the teeth, I extract them one by one. So when we do it digitally, unfortunately here you see it, everything big, but you will see the cross section. I will extract them one by one so I can simulate the day. Today, Raj, he's gonna put the guide on top, then he's gonna start 1, 2, 3. Okay? And I will show you how it is. All right, so now we go. These are the teeth selected. Can you see that it comes, the tooth, it comes with the root? Can you see that it comes with the root? So I want the tooth, not just the coronal part. I want to see the hole, the cratering. I want to see everything. Digitally, that's why like today, for me, it's kind of impossible to do things wrong. We do them because we want them to be wrong, honestly. So now let me go and extract all the teeth. Let me remove all the teeth. And I will show you how the bone will look like. Let me remove the implants as well. And I will show you here. And this is the tissue now after the extractions are going to happen. Can you see how the tissue looks like? All right, and now I bring the bone. I bring the maxilla. Where's the maxilla? It's here. And this is her bone. And I can go and see that if I now remove the tissue, look how the bone it is underneath. Okay? Now that I have the teeth, I have the tissue, I have the bone, now I start planning my wax up digitally. Yes. Yeah. And the extraction they go to plan. Yeah, of course. Yeah. Yes, yes, yes. To be honest with you, like for example, the one that I do not like are the Sirona that we are having a lot of issues. That they make things much, much smaller. Much, much smaller, which is a good thing because it looks like the bone, you don't have bone, but actually you had bone. But the issue is that sometimes for certain FP3 cases, we make the guide on the bone and literally the guide is doing this. When with cheaper version like with the Vatek, there is much cheaper version, we get good fitting, good analysis when we open. So, and now what we do here, okay, we have the wax up. And here we have the wax up bridge. But the wax up, can you see that goes into the bone? It's literally inside the bone, the position. And from the wax up, we need at least 2 millimeters, 2.5 higher. So then what we did, we should have another wax up, the yellow one. No, sorry. I think maybe it's this one here. No, sorry, this is the wax up. The green one is the wax up. The red is where we remove the bone. So what we did digitally, we just duplicate the bridge and we moved the red bridge, we moved it 2.5 millimeters higher in the bone. And what happens, I tell the software from that red bridge, let me go remove the green one a second, and I will bring you now the other maxilla. Can't see anymore. What happened? No. Look now what we did. Can you see this red bridge? We just subtracted from the tissue. So we just say, take this bridge that I went inside the other object and do subtraction. Because the same thing I do for the teeth. I have the file of the teeth, the inside of the bone, and I say, remove teeth number 1, 2, 3, 4, 6, 7, 8 from the bone. And that will create the hole. Okay, so digitally now we can go and see everything. So, and the guides, they've been made based on this that you are seeing there. Okay, so you can see that Raj needs to go and remove the bone up there, needs to remove it here, all across in an anatomical way. And he's going to have the guide that will help him, you know, identify. Okay, do you have any question, anything? Look now at the bridge. Can you see the bridge? Can you see the green bridge?
But it's not about this case, about generally, when would you not do an FP1?
What do you mean? About this case?
You said more or less like you work with protocols. If you see a patient,
yeah,
and you would think this is not an FP1 case.
Yeah.
Do you have any like criteria? Yeah, or you would say this is not an FP1. I would go for FP1.
Yes, massive defect, massive bone defect, bone defects. When we have a lot of irregularity, and then Vitalis, when I used to work, I used to be a technician, not like whatever. I used to know that. I know that Vitalis knows how to do the grafting. I know that he knows how to do it in bone and in tissue. So even if we have here a massive defect, he will compensate it. And then I knew that the other one didn't know. So I will analyze it. But by me not being able to analyze all these kind of aspects, sometimes when the dentists they see that they have defects, they say FP3, which sometimes is much better, becomes less complicated than doing an FP1 and then having recessions.
Because I agree on what you said that the teeth or the case is prosthetically driven. So it's two different things when you just look in the mouth and look in the head. So the teeth are in the head. So the face pictures and maybe the face scans are very useful. So let's say the teeth, I'm not sure how it's going to be here, but you can make a nice bridge on the anatomy you have. But in reality, in the face, the teeth needs to be more forward and downward.
Yes, yes.
And then there's not in between the teeth and the bone, there's a massive gap.
Yes. And also there's a massive difference, like this is a really important aspect. When you don't have teeth, that you put them digitally, don't ever think that they're gonna be like that. That's why I talked about tissue memory here, about muscle memory, sorry. Because once you take a picture with no teeth, and then you put in the face of the patient, is everything false. If you can add things, always do it before going to the surgery. In this case, we cannot go and extract everything and do this procedure, so we cannot retrieve the situation. So then it kicks in a bit more the experience, because I know that this patient, 100% you're going to see her, 100% she's not going to show any more gums in future. But I haven't removed a lot of bone. I have done it in a dynamic way, but I changed the shape. And now on the final, I'm going to go even more out. Okay? But because I play with the arch form. And then how to identify each patient when, if it's an FP1 and FP3, there are different, there are different ways. I have a presentation about that. That is about muscle, position of the lips, situation in the which class of teeth we have missing. Is class 1, class 2, class 3, whatever. Lip dynamics, anything about the 7 millimeters is a hyperdynamic lip, so it's showing. When you have the one that it's not showing teeth whatsoever, then you can do anything, even that you have an irregularity.
Because I love the concept and it's when it's done right, it looks amazing.
Yes.
The best look. But I think of my cases as well. Let's say I had one patient which we've done an FP1 and everything is fine, but her jaw was very down. And smile and have a jaw. And if you don't have one, it ticks the boxes, but aesthetically it doesn't look nice because the teeth don't fit.
Yeah.
You know?
Yeah.
It's like down, you know? It's like no, because the
No,
jaw
no,
is
because
very,
the actual
very
you
narrow.
don't have the space to put the teeth.
Yeah, there's no space. Like we did everything based on the anatomy. But then the teeth are like this, you know, like
Mm.
when you have these orthodontic cases where they align the teeth and they're like, you know, so just to know, you know, when to use what.
Yeah, in that case, like you are limited. When you have a very narrow arch, like you are very limited. Or you do like nearly crooked teeth that you make them look like natural. Otherwise, you don't have space because then they look like, you
Or
know,
small.
yeah,
Or
yeah. But sometimes in those, also in those cases, because you need to go think about this now. Now you have a ridge like this that is very narrow, okay, and the teeth they need to be in here. But because it's a gummy smile, you will need to end up here with your teeth, okay, nearly here. Your CJ, let's say it's here, okay? And now you need to end up in there. By you not cutting the tissue, don't be afraid of opening the arch going out of the bone. Don't need to be in here. You can be in there. Because by you then suturing the tissue against your bridge, you gain space horizontally. Volume horizontally, because you need volume. Then the implant, you just incline it a bit like that, you know, towards the bridge. But it's very important that you maintain the tissue, don't cut it, you don't throw it away. Just leave it to give you volume. Because in a narrow arch, you have very limited space. They are the most difficult cases to be done and executed right. But you need to try to, or you put expanders before you do the surgery, and you expand the arch. Otherwise, you need to gain a bit of volume in tissue.
Bridges we don't have you account with an FP1, you account for say 5-6 years ago.
Yeah, this is another really important thing. So the ovate shape of the pontic is one of the most important things. If I have a socket that is like this, okay, and I want this buccal bone, because the palatal will stay quite nearly always the same. If I want this buccal to reabsorb, because here I have a lower pick, I will do my ovate like this, very shallow. But if I want this socket to be preserved, I go inside, I come, and I go inside my pontic and I come out. And I want you to put some biomaterial just to preserve it. And during the years, if you have used also, that's why then the prosthetic components are really important. If you use smaller components, then actually you have more tissue during the years. You don't see tissue recession. You see tissue growth around the part. When with the multi-units, I have in my practice around 20 cases that I have to redo. Because now the multi-units, they start showing. And I opened in 2020. I used to use them on the Prama. They were really big. The Pada, I remember in the beginning, they were really big. So I had somebody now start coming and showing. But on the fixture head one, never. Never. Not even one. Instead, I have sometimes I have a patient like kind of similar to that case that he has, where we had a really narrow arch, we reduced everything. We didn't remove the tissue, looks everything perfect with the final. Now the tissue has started growing a bit over. So the teeth, they look short. So now I'm doing a guide over the teeth to do just a laser to go and cut the excess tissue. Okay? Any other question? Anything? I think we are good to start then.
So when you have the edgeless area, which is healed a
Yeah.
long time ago,
Yeah.
and then you don't do any sort of grafting in that area.
Yeah.
So you just sort of ovate onto that.
If it's a point, I will remove the point, I will make it ovate.
That still doesn't get recession.
No, no.
See
If
some
it's bone.
cases where the bone is slowly it's just gone.
because you are invading the biological width. So you invaded the biological width, you didn't leave that 3 millimeters for, and the bone will take that shape. If you think about a normal traditional bridge, 3-unit, prep teeth, you have a bridge. So here you have abutment, abutment, tooth, and tooth, and here you have one in the middle, the pontic. So if you do like an ovate pontic in there, and you take a PA in 5 years' time, you see that that bone there has remodeled to the shape of your pontic, if you've done it right. Then if you overlapped it, no. But if you trim, in Italy, we always trim. We trim the tissue and we put an ovate there because we never want to overlap. And then you see PAs that 5 years down the road, the bone actually has taken the shape. Before was straight, now has the shape of the pontic that we went and invaded the biological width. We went like 1 millimeter or nearly touched it, and now has taken that shape. Okay? Yeah. And yeah. The bone is clever. If I need to remove, these are 3 millimeter. I go 1 millimeter, this is gonna go away. Simple. It's a rule. Okay. Any other question? All clear? All right. Raj, whenever you want to start. The patient is here. I saw her, but let's crack on, please.
Straight hand, please. What under the? For which reduction?
The bone, no dynamic.
It's in the box. Right, on the left side. Left side. Yeah.
Straight. One triangle as well.
Perfect.
Yeah.
Perfect. And show it under the camera as well. This is perfect.
This diameter is good.
Hmm?
This diameter is good, right?
This one is perfect. It's perfect. I know that you didn't do it on purpose, but it's perfect.
Yeah.
Yes. Yeah, let's keep both of them here. Yeah. Wait a second. I will do it. Don't worry, I will do it. Yeah. I will do it. Those are the fixation pins, huh?
Okay, I've also got the
Okay, you got them. Okay, yes. Yeah. Oh, if you had them, it's fine. Let's just try first the guide before making incisions because we make sure that everything is fitting.
Okay.
Give me 1 second. I need some more corset, please. Just tell me where it is.
The old downstairs.
Yeah.
I need some more corset, please. Yes, please. You can start taking this. Don't put the target a second, please. Just... Yeah. Yeah. Just put or the guide. Okay. Start with the positioning guide. Davide, not too high because then you're gonna lose. Un attimo. How does it look? Davide, can you now show the camera, please? Start showing the camera. Very good. We will start always from the palatal pin because the palatal pin will hold our guide down. All right, and then we will continue with the rest. Let's just a couple of seconds that he puts the right camera. Okay, that is perfect. All right. I don't know, can they hear me outside properly? Can you go and check? Can you hear me? Is all clear? All right. Huh? Once it's verified. Solo c'è una cinghia.
Dov'è la cinghia?
No.
Si sentono da Dio.
You can hear everything? Is it all good? Yeah. That is good.
There you go.
Yeah. Just put it on focus, Davide. Yeah, it's okay. So I was just saying that it's very important that we always verify that the positioning guide is gonna fit properly without making an incision. And once everything has been confirmed, then we can move to the incision and start with the fixation pins. If you make the patient lift her chin a bit, I think will be a bit clearer. And we are checking the fit through the inspection holes that we left all around. Okay, and we continue. We remove the guide, we make the incision. And the release, we will make it behind the last implants, which they are quite far back. They are on the 7 region. Incision there distally, Raj, just a bit more palatal. So let me just have a look. No, a bit more back, a bit more back. Yeah, there. Do it as distal as possible, please, Raj. So even the last implant, we are not gonna have tissue in the way.
Tanto chiara, vicino non vedevano un cazzo, dovrai neanche di lascio dove di lascio è fighissimo sta roba che cosa stai facendo?
Incision is moved slightly and anterior, move properly.
This is very important because the position where the temper is gonna go and finish is everything pre-planned. So I know where exactly my temper is gonna go and finish. That's why I'm asking him for this reason. So he's gonna have a full flap now on the back. He's gonna be raising a full flap. Yes, yes. In this case, because we have excess of tissue, excess of bone, we are not afraid of, if even if we remove a bit more, we are not afraid because we have excess of everything.
You okay, Jennifer?
Non fa troppo.
Perché se ci mette la mano poi gli altri perché la roba qui è questa che è già registrato, io ce l'ho già così, quindi ho già il file. Allora fare una foto di là.
Should be back in I did 3 of those. Another one. That's it, so thank you. You know, 3 deep breath, Jennifer. 3 deep breath. Through your nose. That's it. There you go. There you go.
Vediamo che la capilla. si vede, insomma, vedi così, che adesso qui al 16 viene controllo la potere, faccio capire perché ti dico secondo me la bella via.
Do that one.
Non te lo fa troppo adesso, non io.
You right, Jennifer? Here. Yeah. Can you get it more?
It's very important that the tissue, when we do the release of the tissue, has to be higher than the position of the fixation pins. Okay? That's why we have raised so high the buccal tissue. So, sorry. Also, it's very, very important that we start with the palatal pin in this case, because we have a palatal pin. And this will help you to keep the guide in position throughout the procedure of fixation of putting the buccal pins. Because sometimes if you start with the buccal pins, the guide will be pushed towards the palatal side. And this will lead then to a misplacement of the implants. Now, it's very important that a nurse will hold it in position firmly, and before starting with the drill, we need to actually again double check. Sometimes you might have a situation where teeth they might be really, really mobile, and the fact to have the palatal pin will help you again locate the guide. And sometimes if they are too mobile, if they compromise the position of the guide, it's better to actually remove the teeth that they will compromise the position of the positioning guide. In these cases, it's better to use a drill extension. When you do the palatal pin, it's better to use a drill extension. You will have easier access because we have the teeth, we have the thickness of the guide, and the whole drill then will go and touch and interfere against the teeth. So maybe Raj, just show it to them how you done it. Yeah. Stay on top of the mouth, please. Yeah, yeah, yeah. Now it's gonna be much easier to go and put it in position. Just perforate a bit the cortical, Raj. Don't go, please, full length. The reason being because we use threaded pin instead of just cylindrical pin, and this is to increase the stability. So throughout all your surgery, we want that the base guide will not move whatsoever. Show the pin, please, that is threaded. Yeah. Yeah. Make sure that you change the setting of the motor, please. Always. Because you will use the settings of 45 speed and 20 Newton centimeters in insertion. Yes. Can I see, Raj? Let's have a look if it's completely flash. Chin up, please. Chin up, Jennifer. Is it completely flash with the? It's flash, yeah. Okay, amazing. Full in, amazing. Yeah. Did you get good stability of it? You felt that there is good stability? Good, very good. Now we'll do the buccal one, the buccal pins, and now we need to focus on making sure that there is no tissue on the way. So the tissue needs to be lifted again, cervically. Let's try to go first with a lateral pin. How does it feel, the guy? Does it feel that it moves now? So as you can see now, Raj is not holding anymore the guide, even that we need to double check, of course, always. But the palatal pin will hold the guide in position against the teeth. And now you have a bit more freedom to put the buccal pins without fighting, let's say, with tissue, holding the guide and so on. Yeah, you can go a bit deeper, just a bit. Yeah, because she's got good density of bone. Sometimes if we have a really spongy bone, like a type 4 of bone, we don't even need to drill, but in her case, we have a good. And that's it. We arrived. Yeah. Now we continue all across. Now the next two fixation pins, you can drill both of them and then go with both screws. And again, we hold the guide always during this process, because sometimes with our drill, we can actually move the base guide. That's correct. This one, the difference from the traditional pins, that they are completely rounded, that sometimes during the vibration or the preparation of the implants, the base guide might start moving. That's why we kind of did it with the threads, so it does not move. You're gonna see until the end of the surgery, this will not move. The guide will stay in the same position. we usually put in 4. We use simple concepts like of a table.
Yeah.
A good table needs 4 legs. Mi disattivo solo da là, quando è green sta funzionando, quando non è green non funziona. Va bene. Perfetto, grazie. Can you see that Raj's hand? I don't know if you can see it, but it's shaking a bit. He's trying to push it. That is a good sign. It means that we have not over-prepared for the fixation pin, so the pin is going into good bone. It will give us a very good solid guide throughout the surgery. Yeah. And now we are gonna go and double check that everywhere it's seated correctly. If all okay, now we remove the frontal pin with a screw. We just unscrew just one pin.
You okay, Jennifer?
And we'll remove the guide. Okay, and guide out. Now the next step is gonna be the XLAs. XLAs and cleaning of all the area where there is any granulated tissue, infection. All right, now you're putting the blue guide on to check for the bone levels. Your head away, Raj. Move your head away so you can show it to the camera. Yeah. And this one is up to you if you want to put the screw, because it's just to stay there, just to guide you. You can screw it, but okay. Very good. Very good. Now you can start trimming. Okay, and you need to go until the level of the guide. Interproximally, I would like that you leave me just a bit lower bone. Not, don't leave me the peak. Yeah, just rounded it.
Yeah. Now it's the bugging, okay?
Okay, now is the time that we are going to take the bridge before we start preparing for the implants, and we make sure that we have enough biological space. Raj, insert it at the back. Move the tissue away. And then come from the front to the palatal.
Yeah, I'm just raising the palatal flap to
So because in this case we have quite excessive tissue, was not allowing us to sit down the temp in place. So what is Raj doing in this case is just raising the palatal flap to accommodate the temporary, so we can check that we have enough biological width all around.
yeah, yeah.
There is a pickle bone, correct? Yeah.
And there is the palatal bone in the upper right.
Yeah. So we're gonna adjust those and then we recheck it until we make sure that we have enough biological width and the temporary is seated. we will not proceed with the preparation of the implant. You don't need that, Raj. I don't think you will need the guide back. We'll just interfere. Now we'll double check again.
Yeah, the distal of the one, distal of both the one, yeah,
Yeah. All right. So there's two more areas that we still need to adjust more. Okay, and the reason that we are doing this operation before we place the implant, then once the implants are placed, we can risk them to damage the connection of our Profilo, or if you use a normal multi-unit, your normal multi-unit. So it's always better to check now with the prosthesis and make sure the prosthesis fits. Let's move the tissue away. How are you doing, Raj? So distal over the upper left one a bit. On the 6. Middle of the 6. Okay. Do you have tissue on the way? It's in. Now just check with the probe anteriorly, especially that you have enough space, at least 2 mil. This would have been much easier if it was an FP3. Or no, Raj. If it was an FP3, it would have been much easier. just chop down all around. Pay a probe, the small one. That is and we go and check. We put it from the CJ to the bone. Let me check it visually. No, just put it like this, like where the tooth is. Yeah. In an angle. Just get an angle. Yeah. But we have sufficient space there, all across. Yeah. Yes. Definitely we have sufficient space there. Check on the other side. Yes. Okay, I'm happy. Just give me maybe just a bit more space now that you remove it on the canine, please. Just on the canine, yes. Just do me a bit of an ovate. Just on over novate, and that's it. And then we can put the preparation guide, so we can start the. the preparation for the implants. Just in the middle, Raj, not buccally, just in the middle. Perfect. 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 Now I'm happy.
Can we see outside? Can we see outside? Can we see it outside as well?
Sorry?
Can we see it
Yeah,
outside?
yeah, yeah.
Yes, yes.
Okay.
It's perfect, Raj.
Okay.
This is perfect. Yeah.
It's always challenging and nice to do.
Hmm?
51 is always challenging but nice to do.
Yes.
53 is a lot more
Yeah, it's straightforward. It's easier because you just cut straight, bang, bang,
flat.
flat, stick the implants in, and it's done.
You right, Jennifer? You right?
25.
Little clean up and then do the next one. Are you comfortable? Yeah.
Okay, now he's going in the preparation guide for the implants. And we need to make sure in this case again that the tissue, we move it away because we have quite an excess.
Come mancherà adesso? Quanto mancherà adesso?
So I've noticed that the sleeve on the distal where it does the angle is touching a bit of bone. So now he's just gonna create a bit of space for the guide to sit fully. This is very important, not to rush it or not to force it. The preparation guide for the implant needs to sit passively. So the interproximal bone that we left between central and upper right and upper left is still touching a bit. So we need to reduce it.
What's it doing? Here's the feeling.
So we are opening a bit the distal tissue because that was the area where, let's say, the 7 region implant is being placed and is touching. So there was not raised a flap, and was really much interfering with the guide. Now we'll double check again. Raj, can you please show where is the tissue, because I don't think they can see it from outside. You need to lift the chin a bit. Yeah, you need to lift the chin up for the patient. Yeah.
Open, Jennifer. Open. That fish hook. Can you see?
They can't see now. The chin needs to be higher up.
Jonathan, look up. Lift up your chin.
Yeah.
That fish hook.
Yeah. Yeah.
Open. Hold on.
the frontal pin needs to be very firm by hand, but I'm saying like just because you're gonna cause vibration now, movements.
It seems okay.
Good, very good. Let's just go ahead then. And we do one burr all across, correct? I will give you the sequence like this. Do you want to prepare distal? You want to place distals as well, yeah?
Yeah, yeah.
Yeah, everything.
Ready?
Yes. I will start with the first drill all across, Raj. So just the start. Go with the start. I wouldn't use the bone profiler. Unless we need it, I wouldn't use it.
Okay.
Water? Do we have water?
Yeah, I'll get the coming again.
Okay. Raj, first insert. Please, first you insert inside the sleeve
And then done.
and then go, because if you start drilling, now you're gonna start drilling the sleeve
Okay.
because of the precision of them. Yeah, like that. Perfect. Like that. You go in and then you rotate. Because otherwise you're drilling, you're forcing the sleeve in a different path.
Open a little bit on the side. Thank you.
This is a very nice trick of Raj that he's using in his left hand. Actually, the left hand always helps to create less tension on the guide. Raj, insert first, please. Insert first.
I'm going to do it to the profiler because there is resistance to it.
Is everything okay?
Yeah.
So,
I cannot see from here, but then go with the bone profiler, but
you feel it.
then go with the bone profiler.
Open again?
There's a 30-degree angle that.
Take deep breath through your nose. Take a deep breath through your nose, Jennifer. Take a deep breath through your nose. 3 deep breaths. Yeah, take deep breath through your nose. 1. And again. And one more time. Much it there. Good. Well done. Thank you.
Raj, even in these cases, it's better to use an extension, but if you can use it, it's fine. Usually for the distals, extension. So you have a nicer access. Your head is right in the middle. Huh? I don't think they can see from outside. Now we go 6.5, Raj.
6.5 solid.
Yes. All across.
No, there's one of the, there's one of the,
Come on the face. And then the fucking thing.
Do you need it now, Raj? Don't force it because it's the bottom of the burr that is touching against the palatal bone. It's the bottom of the burr, of the guidance of the burr that is touching against the bone. It will not go deeper now that you're pushing. If you want, you can just use the bone profiler later on. Please move your head a bit. Shall we do the 6 anteriors, Raj, where we are doing the pickup, and the other two you do them later? So we can do the pickup and I can do the bridge as well. Always find first the path and then rotate.
that's the only one where people look resistance.
It's the angle that you're using now.
I'm doing that at the end.
Huh?
I'll do the distal at the end. I'll do the distal at the end. Or the
Yes.
carry on.
Yeah, I will do the two distals. Let's do them at the end. Let's put this because we are doing the pickup on the 6 anteriors. 8.5? Yes. Until I told you to change bird, just use the same one, please. Yeah. Okay. Now, through this first drill as well, what we can understand that the patient has really high density bone. So we are not aiming here for under preparation of the implants. No, insert it, please, please. Yeah. I can see it from here that you're not in the correct axis. Turn the handpiece like this, right? Yeah.
Open. Thank you.
Okay, now do the distal.
Yes.
Do the distal.
Open.
Okay. 11.5, the same one.
Open. This side and the front.
Change saline. I will do it. I will bring it to you. Good.
Open, please. Thank you.
No. Raj, just remember the path. Because you're going totally different path, huh? Yeah.
Open. Open. Open big. Clean out all access. Hold on. Thank you. Open.
You can go with the 13 or 15. Even with the 15, you can go. Huh? They are all. We have 113, but we have bone.
You okay?
Okay.
You did bathroom?
I think. Can we hold on just for the preparation? Jennifer, can you hold on 5 minutes?
Yes.
All right.
Yes.
Because we cannot remove this guide. This is 15, yeah?
Open one. Thank you. Open.
Find the path, yes. If you find the path, you'll see that it just dropped by itself.
Open. Okay.
You have very high density rods, huh? Now go with the 15 next burr. 2.8. All across, right? Next burr across.
Yeah.
Yeah. Just go across now.
So,
No, go 3.5. You did the 2.8? 3.5?
no, 3.5 and 15.
15. 15. Now you just go 15, 15.
Okay.
La moda sempre calza. Need to angle more back a little. Right. Non lo so.
3.8,
3.8,
15.
15. This one, the two anteriors are 3.5, so you don't do full length.
Okay.
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 But still use that burr. Because I think that we have
Then
very dense bone. It's fine. Okay. Okay. Right. Just a bit with the next burr, 10 millimeters. On the rest, not on the two anteriors. Not on the two centrals, all the rest with a 10. Because I think that, we are going to get really high stability. Amazing. Now the implant preparation, we are done. Can you just please maybe ask Jennifer if you can place the implants or not, or should we let her go to? We should let her. Okay. All right. Okay, amazing. No, no, it's not that one. It's not that one. No, no. No. 4. That is 3. That is 3. Guys. Yeah. Yeah. That is the upper right for where he is going now. Before wasn't the 3. Just align properly with the line, Raj. Make sure that you have light, enough light there. That you're aligned with the hole. Use the hand ratchet.
Yeah, underneath.
Go more, go more. For sure you're gonna have more torque. Because now you're against the sleeve because you didn't go, Raj, was not parallel to the sleeve. You went against the sleeve and now you're in friction. But can you hold the axe, Raj?
No.
Can you hold the axe on top of it? Yeah. Put full torque. Don't do that, please. Don't do that. Don't do that. Okay, let's go in. Because you're in friction now. It's not you're getting that torque.
And the line should be in.
One more turn and now you should align. Can you see that the line, you already touched it? Now you passed it, to be honest.
Yeah.
Just twist it more. But you need to have suction, you guys. We cannot work like blinded. For me, like it's impossible to see. Is this light working?
No, it's turned off.
No, I turn it on. I need to see. It's on, but it's a low setting or there is something because it's not possible. Suction, please, suction. Let me see where it is. Where is the alignment? The alignment.
The line.
Alignment.
No.
The hole, the hole.
Yeah, no, that is here. That's on the buckle. I believe.
No. That is there.
That's here. The hole is here on the buckle.
You're sure?
So the next time, yeah, it's there.
Yeah.
So the next time, if you come there,
No.
yeah, that's the hole.
I know, Raj. I know. I know. Go rotate more. Right, but hold the axe, Raj, because you're gonna.
Have a look.
Come on, Raj.
No.
I know. You are opposing, Raj.
You're on 1725.
Raj, just give me space, please, so I can record a sec.
You get something. Oh.
You see here, I cannot see it.
I think that's frozen. Yeah, David, it's frozen.
It's frozen. When you go there, it's frozen. Always. It's frozen. Even earlier. I know. Even earlier, I was saying that it was frozen.
It's lagging.
Just go slowly. Wait a second, Raj. Raj, wait a second. Did you activate the camera from there, please? So, can we please just tell them where is the notch? Indicate them. There is a buccal notch. Take a probe that he needs to align. There's a buccal notch in there, and then is the opening for the screw, and then there is a line for the depth. Put it under the camera because you're too far. Your head closes all the light. Yeah, it's not on focus. It's not on focus. Dobbiamo essere veloci perché ha perso l'impianto in bocca, hai visto cosa è successo?
È così centrale.
No. But Raj, do you go in the mouth? It's in the mouth. It's okay. Just a little saline. Just make it go the saline. We work 100%. All right. So we need to remember. Again, we'll say that, but push it, Raj, please.
Why?
Remove your head, please, so they can see it from outside. There, you're good.
Another two. One's in lot. Nice and slow. Yeah. Get them all lined up. Always about two more.
What, sorry?
I think it's on
That one is in the back. I need to go on the palatal.
but this one here.
And the line here is the line of the depth.
Yeah.
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 One more time to go on the line, and then
Find that line again.
You can. Yes, please for final.
Are you in high torque now? You got to the torque, to the motor torque? Yeah.
No, just off, you get one whole rotation, bring it around, people like, yeah?
Raj, please go and explain it outside as well to the people now, this alignment, please, of the notch. Move your head, please, Raj, please. I know that you would like to see it, but no, there you need one more turn. Move your head, Raj. Now you're buckle with the screw axis, yeah. Now you just need to bring it buckle. Align it suction there very well, please. No, on the buckle. Where is the notch? Move your head, Raj. Perfect.
Adesso ne fa un altro di te.
Yeah.
Già di là.
Just the Profilo tuck. Very nice and firm. It will not drop. Try to drop it, Raj. Just try to drop the Profilo. You're not recording, Davide, eh?
È piccolo.
Sì.
Quella di sinistra devi mettere il telefono di
Su quello di sinistra il telefono iPhone DVD. È bloccato come prima.
se c'è qualcosa qua che gli blocca il segnale.
Show the two parts together, please, Raj. Under the light. Okay. Let's go. Yeah. Turn the head of the patient a bit. Yeah.
Devi portare l'iPad.
Align it now. Now you are the pro, so Now all the mounters are out. We'll just remove the frontal pin. Okay, we remove the frontal pin.
Once, no, after 10 minutes.
Tell me if I need to cover up.
Okay, and at this stage, can you put the chin up and wash a bit, please? All the profilos are in. Davide, puoi riprendere qua Davide, per favore, ma non si riesce.
Lo vuoi riprendere?
È il profilo, la cosa di importanza.
Ah, lui, il backup room? Sì. Allora, vai.
No, no, no. How do they look? Looks okay. All good? All very good, Raj? Shall we do the pickup now, please? You need some flowable and the most powerful light here you have. So we put the bridge first. Okay. We need to wash it. We'll we need to wash it properly, Raj, like water and air, not like